Hey everyone, Chris here from MedPrep2Go, and I want to take a quick break to announce that our first course is now live. Comprehensive Endocrinology is a video series with Dr. Raj Dasgupta that features 9 hours of content in 8 modules. This course is useful for learning endocrinology for internal medicine, family medicine, USMLE Step 3, and COMLEX Level 3. And this content is exclusive to the video series and won't be available on any of our podcasts. Keeping with our philosophy of making medical education affordable and accessible, this course is available for just $10 a month or $20 for a year. So check it out now and start learning at medprep2go.com. And stay tuned for more courses coming later this year. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We would greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In today's episode, I'll be reading 3 more endocrinology questions from our online Qbank, and as always, you can read these questions and more at medprep2go.com. And with that being said, let's get started with question 1, Endocrinology 10. A 30-year-old woman presents to the clinic with complaints of frequent headaches, fatigue, and muscle weakness over the past several months. She has also experienced episodes of palpitations and increased urination. Her blood pressure has consistently been elevated, averaging 160/100 over the last 3 visits. On today's measurement, the blood pressure is 158/98, but other vital signs are normal. Physical examination is unremarkable. Laboratory tests reveal the following: sodium 144, potassium 2.8, bicarbonate 29, serum creatinine 0.9, and glucose 90. A CT scan of the abdomen reveals a 2.5 centimeter mass in the right adrenal gland. Which of the following is the most appropriate next step in the management of this patient? Is it A, computed tomography angiography of the abdomen? B, dexamethasone suppression test? C, plasma fractionated metanephrines? D, plasma renin activity and aldosterone concentration? Or E, urine potassium excretion by 24-hour collection? And the correct answer is D, plasma renin activity and aldosterone concentration. This patient's clinical presentation, including hypertension, hypokalemia, and the presence of an adrenal mass, is highly suggestive of primary hyperaldosteronism, otherwise known as Conn syndrome. Primary hyperaldosteronism is characterized by excessive secretion of aldosterone, usually due to an adrenal adenoma or bilateral adrenal hyperplasia. This condition leads to serum retention, potassium excretion, and secondary hypertension. To confirm the diagnosis, the best next step is to measure plasma renin activity and plasma aldosterone concentration. In primary hyperaldosteronism, the PAC is elevated and the PRA is suppressed, resulting in a high PAC to PRA ratio, typically greater than 20. A PAC greater than 15, along with a high ratio, strongly suggests primary hyperaldosteronism. Answer choice A, computed tomography angiography of the abdomen, is incorrect. CT angiography of the abdomen is used to elevate renal artery stenosis or fibromuscular dysplasia, which can cause secondary hyperaldosteronism, but this is not the first step given the patient's presentation. Answer choice B, dexamethasone suppression test, is incorrect. A dexamethasone suppression test is used to diagnose Cushing's syndrome, which presents with features such as central obesity, purple striae, and glucose intolerance, which are not seen in this patient. Answer choice C, plasma fractionated metanephrines, is incorrect. Plasma fractionated metanephrines are measured to elevate for pheochromocytoma, which can cause hypertension and palpitations, but does not typically present with hypokalemia or an adrenal mass that suggests hyperaldosteronism. Answer choice E, urine potassium excretion by 24-hour collection, is incorrect. Urine potassium excretion by 24-hour collection can help evaluate potassium loss, but is not the best initial test for diagnosing primary hyperaldosteronism. Key learning point: in a patient with hypertension, hypokalemia, and an adrenal mass suggestive of primary hyperaldosteronism, the best next step is to measure plasma renin activity and aldosterone concentration to confirm the diagnosis. Question 2, Endocrinology 11. A 28-year-old woman presents to the clinic with complaints of excessive hair growth on her face and body, irregular menstrual periods, deepening of her voice, and unexplained weight gain over the past 6 months. She reports that her last menstrual period was 2 months ago. Her medical history is unremarkable, and she does not take any medications. Her BMI is 29, blood pressure is 140/85, and pulse is 75 per minute. Physical examination reveals temporal balding, acne, and hair growth on the upper lip and chin, and clitoromegaly. Laboratory results reveal the following: serum 140, potassium 4.0, glucose 95, and TSH of 1.8. Which of the following is the most appropriate next step in the evaluation of this patient? Is it A, 17-hydroxyprogesterone level, B, dexamethasone suppression test, C, insulin-like growth factor 1 level, D, plasma fractionated metanephrenes, or E, serum testosterone and dehydroepiandrosterone sulfate levels? And the correct answer is E, serum testosterone and dehydroepiandrosterone sulfate levels. This patient presents with signs and symptoms of hyperandrogenism, including hirsutism, temporal balding, clitoromegaly, and deepening of the voice. The rapid onset and severity of these symptoms raise suspicion for an androgen-secreting tumor, either ovarian or adrenal in origin. Hirsutism is defined as excessive male pattern hair growth in women of reproductive age. It may be the initial and possibly only sign of an underlying androgen disorder, the cutaneous manifestations of which may also include acne and female pattern hair loss, also known as androgenetic alopecia. The most common cause of hirsutism is polycystic ovary syndrome, PCOS. In some cases, hirsutism is mild and requires only reassurance and local therapy, while in others, it can cause significant psychological distress and require more extensive therapy. Measuring a serum total testosterone is appropriate in all women with clinical evidence of hirsutism, defined by the presence of excessive terminal hair growth in androgen-dependent areas. The choice of additional tests is based upon the patient's presentation, including time of onset, pace of progression, presence or absence of virilization, and menstrual cycle status. The initial step in evaluating suspected hyperandrogenism should include measurement of serum testosterone and dehydroepiandrosterone sulfate, otherwise known as DHEAS levels. Elevated testosterone levels with normal DHEAS levels may suggest an ovarian source, while elevated DHEAS levels might indicate an adrenal source. Answer choice A, 17-hydroxyprogesterone level, is incorrect. Measuring the 17-hydroxyprogesterone level is useful for diagnosing congenital adrenal hyperplasia, CAH, but the rapid onset of symptoms and significant virilization in this patient make CAH less likely. Answer choice B, dexamethasone suppression test, is incorrect. A dexamethasone suppression test is used to diagnose Cushing's syndrome. While Cushing's syndrome can cause hirsutism, the prominent virilization symptoms in this patient make an androgen-secreting tumor more likely. Answer choice C, insulin-like growth factor 1 level, is incorrect. An insulin-like growth factor 1, IGF-1, level is used to diagnose acromegaly, which can cause hirsutism, but is typically associated with features like enlarged facial features and macroglossia, which are not present in this patient. Answer choice D, plasma fractionated metanephrenes, is incorrect. Plasma fractionated metanephrenes are used to diagnose pheochromocytoma, which presents with paroxysmal hypertension, palpitations, and headaches, not hirsutism and virilization. Key learning point. For a patient with rapid onset hyperandrogenism, such as hirsutism and irregular menstrual periods, the best next step is to measure serum testosterone and DHEAS levels to identify a potential androgen-secreting tumor. Quick question for the parents: when was your child's last eye exam? Myopia, or nearsightedness, is becoming more common in kids, and it's not just about needing stronger glasses. As you know, if myopia continues to progress untreated, it may increase the risk of more serious vision complications later in life. The good news? An eye doctor can help identify myopia early and recommend options designed to help manage it over time. One of those options is Essilor Stellest lenses. Stellest lenses are designed specifically for children and are part of an approach to myopia management that corrects their vision while supporting eye health as their eyes continue to grow. They look like regular eyeglasses, but they're purpose-built for young wearers. Every child's vision is different, which is why starting with a professional eye exam matters. If you have concerns or even just questions, your eye doctor can guide you through what solution is best for your child. Clear vision today can help support your child's future, and it all starts with an eye exam. Visit Essilor.com to learn more about Stellest lenses and to find an Essilor expert eye care professional near you. That's ESSILOR.com. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Question 3, Endocrinology 12. A 40-year-old man presents to the clinic with a 6-month history of fatigue, decreased libido, and erectile dysfunction. He has a past medical history of hypertension and is currently taking amlodipine. He reports drinking 1 glass of wine per week and does not smoke cigarettes or use illicit drugs. He exercises regularly. Vital signs are within normal limits. Physical examination reveals bilateral gynecomastia. There are no visual field defects or other neurological abnormalities. Laboratory results show the following: hemoglobin A1C 5.7%, FSH 2, LH 3, testosterone 160, and TSH of 1.2. Repeat early morning testosterone level is 155. Which of the following is the most appropriate next step in the management of this patient? Is it A, discontinue amlodipine, B, measure serum prolactin level, C, measure transferrin saturation, D, prescribe sildenafil, or E, ultrasonography of the testes? And the correct answer is B, measure serum prolactin level. This patient presents with symptoms of secondary hypogonadism as indicated by his low testosterone levels and inappropriately normal gonadotropin, FSH and LH, levels. Secondary hypogonadism can be caused by various factors, including mass lesions in the hypothalamus or pituitary, hyperprolactinemia, long-term use of glucocorticoids or opiates, and severe systemic illness. The most appropriate next step from the provided answer choices is to measure serum prolactin level, as elevated prolactin can inhibit gonadotropin-releasing hormone, GnRH, secretion, leading to low levels of FSH and LH and subsequently low testosterone. Additionally, patients with elevated prolactin due to prolactinoma may have headaches and visual field defects due to compression of the optic chiasm by a pituitary adenoma. Answer choice A, discontinue amlodipine, is incorrect. Discontinuing amlodipine is unlikely to resolve the patient's symptoms, as antihypertensive medications generally do not cause significant hypogonadism. Answer choice C, measure transferrin saturation, is incorrect. Measuring transferrin saturation could help diagnose hemochromatosis, but this condition typically presents with other symptoms such as skin pigmentation and diabetes, which this patient does not have. Clinically significant iron overload causes increased serum ferritin and transferrin saturation. Answer choice D, prescribed sildenafil, is incorrect. Sildenafil can help with erectile dysfunction, but does not address the underlying cause of this patient's hypogonadism. Answer choice E, ultrasonography of the testes, is incorrect. An ultrasound of the testes may be useful in evaluating primary testicular failure, but it is not indicated here since the patient's findings suggest a central cause of hypogonadism. Key learning point. In a patient with symptoms of secondary hypogonadism, such as low testosterone and normal gonadotropin levels, the best next step is to measure serum prolactin levels to evaluate for hyperprolactinemia, a common cause of central hypogonadism. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Hey everyone, Chris here from MedPrep2Go, and I wanted to tell you about our MedPrep2Go Step 3 Review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.